Okay, today we're going to be discussing the science of biochemistry and its associated metabolic disorders. Now let me just point out, this is definitely one of the hardest of my lectures, not because, it's complicated like neurology, hematology, and cardiology, but rather there's these very long, painful, words that, really make it hard for students to properly understand and to memorize. I might hate to turn off anyone, but just the enzymes that we're going to be dealing with, I stopped counting over 100. So you could imagine, how much product, how much of the substrates, the cofactors, the regulators, pharmacology and pathology is over here. It is definitely a lot of information. Now, I'm not saying that you really honestly have to know everything in this lecture in order to be a great doctor. Obviously, I'm sure there are great doctors who really probably can't tell you over one pathway in biochemistry and yet still are great doctors. Of course, absorb what you could absorb, get what you could take. And as you listen to these lectures one or a couple more times, obviously you'll pick up more concepts and more ideas that we're going to be going through today. Now, those of you who are listening to these lectures because you really want to ace the biochemistry portion on the board exam, I highly suggest that you especially pay attention and especially take notes on the points which, number one, the enzyme and the steps which have regulations, which have cofactors, and the ones that are associated with some type of pharmacology or pathology. Okay. Now we're gonna get right into the biochemistry now. Now, before we get into all the different biochemical pathways, what's very important is that in every single pathway, in order to get from, let's say, A to Z, okay, this is going to be requiring enzymes. Enzymes are needed to get from A to Z. Now, a lot of students unfortunately make a mistake to think that enzymes actually cause chemical reactions. That's actually not true. Enzymes don't cause chemical reactions. They really only help facilitate one. For an example, if I were to have a glucose molecule, automatically the glucose molecule on its own will eventually be converted to carbon dioxide and water. Okay, it might take 1,000 years for this to happen, but bottom line, this does not require an enzyme. It would happen spontaneously. The question is, why is this taking 1,000 years? And the answer is because anytime a substrate wants to convert into a product, the substrate needs to actually have enough energy in order to be converted. So what do? For 1,000 years, let's say, for example, we go and we keep on adding energy. We keep on putting batteries into the substrate. And eventually, after, let's say, 1,000 years, when it finally has enough energy, then the substrate will on its own be converted to a product. Now, this energy that we just talked about is referred to as delta G++. Now, delta G++ is very important because it's the energy a substrate needs in order to be converted into a product, okay? Now, what enzymes does here is enzymes basically lower this delta G++. In other words, instead of needing, let's say, 1 billion batteries for the substrate to be converted, now it says, you know what, you only need 1 battery to be converted to a product. Thus, it lowers the activation energy for the delta G++, thus allowing the substrate to convert to a product at a much lower energy level. Now, like every protein in our body, like everything in our body, everything has a charge, whether it's amino acids, whether it's a substrate, whether it's a product. Now, a product, let's say, has an energy of +10, and let's say our substrate has an energy of +10. By the way, energy is referred to in biochemistry as G. So Gs, let's say +10, and Gp is +10. That means that the delta G is going to be equal what? First of all, what is delta G? Delta G is the difference between energies, the difference between the product as the substrate. Delta G is equal to Gp minus Gs. So Gp is 10 minus Gs is 10, so delta G is going to be 0. Now, anytime we have a reaction that delta G is 0, this tends to be a spontaneous reaction and usually is reversible. What does reversible mean? Meaning the same enzyme which is able to take it from the substrate to the product is the same enzyme that's also able to reverse it, take the product back to the substrate. Why? Because the energy levels are the same. Now, the second example, the second situation we could have is, let's say we have a GS, let's say 12, while GP, let's say, is 10. So in this case, what's happening is the delta G in this case is going to be delta G. Remember, GP minus GS. So 10 minus 12 is going to equal positive, specifically +2. And if, again, anytime you have a positive delta G reaction, these reactions tends to be, number one, a spontaneous reaction. Number two, it's also irreversible. Why is it irreversible? Because anytime we're dealing with energy, an enzyme is unable to really reverse a substrate to a product when there's an energy difference within its reaction. Okay. Also, if you look very closely at this reaction, what has to happen here, in order from the substrate to get to a product, in order from 12 to get to 10, this actually has to lose energy. And of course, that is what's going to happen. And of course, anytime a substrate loses energy, we take that energy and we actually use that energy. So a positive delta reaction means that we're gaining energy. Okay, and the last example that we can have is, let's say a GS is going to be 10 and the GP is going to be 12. And of course, in this case, the delta G is going to be negative. Why? Because GP minus GS, 12 minus 10 is going to be equal to negative 2. And again, anytime you have a delta negative reaction, this tends to be also, this instead of a spontaneous is usually a non-spontaneous reaction. It's also irreversible because we're unable, because the enzyme is dealing with energy. And also, obviously, if you look closer, what's happening over here, in order for us to convert from GS to GP, we actually have to add energy within it. So in other words, we're losing energy. We have to invest energy within the substrate in order to make a product that has a higher energy than the substrate. Now, let's say I have a cell, and let's say start to put substrate within the cell. So obviously, the more substrate I'm going to put into the cell, obviously the more product I'm going to be making. Why? Because I have enzymes in this cell. However, because I have a limited amount of enzymes, if I keep on increasing the substrate, because again, all the enzymes are going to be fully saturated once too much substrate comes in, eventually I'm going to have a plateau, and I'm not going to further make substrate, I'm not going to further make product if I keep on adding substrate. This plateau is referred to as a Vmax. Okay, a Vmax again is what is the substrate levels concentration when all 100% of enzymes are fully saturated. And a very, very important concept that we have to discuss, and we're going to be using over here, is that the Vmax, okay, is fully proportionate to the number of enzymes within a cell. Okay, that's the first concept that you have to know for right now. Now, let's say I have 150 enzyme within a cell, okay? And I'm telling you that the enzyme substrate ratio is going to be 1:1. That means that, let's say the Vmax is automatically going to be 150. So that means that the Km is going to be 75. Why? Because what is the Km? The Km is what is the substrate levels concentration when the Vmax is 50%. And because the enzyme's Vmax is 150 and the ratio is 1:1, so the Km is going to be 75. Now, a lot of times the board likes to trick you guys to think and to always make believe that Km is always going to be 50% of Vmax. That's actually usually not the case. I mean, this case happens to work out perfectly, but really Km is really dependent on the enzyme's function. For example, if I have an enzyme that is shaped properly and it's able to bind properly with its substrate, so its affinity is going to be increased. And when its affinity is going to be increased, what's going to happen is the second I put substrate into a cell, the second my enzyme sees the substrate, if it likes it a lot, it's going to go and the charge on it is going to bind to it. Therefore, I'm going to have a lower Km. I'm going to saturate 50% of the enzymes a lot faster, as opposed to, let's say if I have a enzyme which is not compatible and it's not properly shaped. In other words, it has a decreased affinity to its substrate. In that situation, when I put a substrate into the cell, it's not going to like it, it's not going to be attracted to it. Therefore, it's going to take its time, and therefore, it's going to take us a lot longer in order to go and saturate 50% of the enzymes because it has a decreased affinity. So the second very important concept that we have to develop here is that the Km is going to be inversely proportionate to the enzyme's affinity. Okay, and this is a second very important concept. Now, the last thing you have to know about enzymes is what are the factors in our body that are able to actually affect and influence this Vmax and the Km. Okay, and very important, there are two graphs that we actually have to know this with. Number one is you have the graph, and number two, you're going to have the Lineweaver and Burke graph. Okay, in the graph, what's going to happen is on the x-axis is you're going to have your substrate, on the y-axis you're going to have your product. This is going to be your line, this is going to be your Vmax, and of course, this is going to be your normal Km. And on the Lineweaver and Burke graph, on the x-axis you're going to have your 1 over substrate, the y-axis you're going to have 1 over your product. Here's your line. The line that intercepts with the y-axis is going to be your 1 over Vmax, and the line that intercepts with the x-axis is going to be -1 over your Km. We'll just fix that. -1 over your Km. Okay. Now, what are the factors that can affect Vmax? So now, there are two things that could affect Vmax. The first thing that could affect Vmax is a non-competitive inhibitor. And the second thing that could affect the Vmax is going to be a gene expressor. Okay? With a non-competitive inhibitor, what a non-competitive inhibitor does, it basically goes and binds to an enzyme, but it binds to an enzyme in a way where it screws up its shape so badly where it's really uncompatible to even bind to a substrate anymore. In other words, it makes it 100% worthless. And a worthless enzyme is obviously going to be an enzyme that's not there. So, because we know Vmax fully proportional to the enzyme's number, or a Vmax fully proportional to how much functional enzymes we have, because we're going to decrease functional enzymes, we're going to be decreasing the Vmax in these patients. Okay? So therefore, we're going to decrease Vmax. And on the Line-Weaver-Burke graph, again, remember, because it's a fraction graph, up is really down and down is really up. So if we're going to be decreasing the Vmax, this is going to be going up like this. Okay? And regarding a gene expressor basically goes to the genetics of the gene, and it leads to the expression, and it leads to more numbers of the enzyme. In other words, it's going to increase the number of the enzyme, which, remember, is fully proportional to the Vmax, so the Vmax is going to increase. Therefore, of course, the Vmax is going to increase. And vice versa, on the Line-Weaver-Burke graph, the Vmax is going to increase. Now, note over here, and again, it might not look like that, but the Km in both a non-competitive inhibitor and a gene expressor are not going to be affected. Why? Because, again, it's not affecting the actual shape, it's only affecting the number of enzymes. Now, regarding the Km, again, there are also two factors that are able to affect the Km. Okay? Number one, you have a competitive inhibitor, and you have your gene or enzyme activator. Okay, with a competitive inhibitor, what's happening is it basically goes to the enzyme and it binds to the enzyme, but it doesn't make it worthless. Rather, it just makes it shaped a little different. In other words, it decreases affinity. And when you're going to decrease affinity, because it's fully proportional to Km, Km is going to increase. Therefore, the Km is going to increase. Okay, and vice versa, the Km is going to increase. But however, remember, the Vmax is still going to stay the same way. However, if we're dealing with an enzyme activator basically go to an enzyme and basically will stimulate it and actually change its shape, but in a good way. It will increase affinity. And because Km is inversely proportional with affinity, if you're increasing affinity, that means you're going to lower the Km. And therefore, you're going to increase the Km in these situations. In other words, the second you put in substrate into the cell, the Km is going to bind. So just to summarize, a non-competitive inhibitor is going to decrease the Vmax, non-competitive inhibitor is going to decrease Max. A gene expressor is going to increase the Vmax, a competitive inhibitor is going to increase the Km, and a gene activator is going to decrease the Km. Okay, you can stop. Okay, now before we get into the further biochemical pathways, we're first going to be discussing vitamins. Now, vitamins is unfortunately a very controversial subject. A lot of doctors, nutritionists, and sometimes even grandmothers are always telling you that, they might not be important to you, they don't really aid in any single process. So let me tell you this. Anyone that says that has the slightest clue of biochemistry. Vitamins are an extremely important process. They aid in many different functions, from healthy epithelium to coagulation to calcium to night vision. But by far the most important function of vitamins is to provide cofactors for enzymes. A cofactor for an enzyme is one we spoke about before about affinity. So a cofactor really basically goes to an enzyme and changes its shape where it increases its affinity to bind to its substrate, which thus makes it extremely important in the way enzymes function. Okay, now, before we go into the stuff vitamins, I just want to warn everyone that if those of you who are not familiar with biochemistry, this is going to sound like Chinese to you. And those who know Chinese, it's going to sound like Japanese. So you got to bear with me for now, but I guarantee you, when we finish this lecture, you're going to go back to it, and I guarantee you'll listen to everything that I'm going to be saying. Now, vitamins can be split up into two different sections. You have your water-soluble vitamins, and you have your lipid-soluble vitamins. The lipid-soluble vitamins are vitamin A, D, E, and K. Okay? The water-soluble vitamins are going to be B1, B2, B3, B5, B6, B7, B9, and B12. I mean, technically you also have vitamin C, but we're not going to talk about that now. B1 is also known as thiamine. Now, thiamine is an extremely important cofactor. It provides it provides cofactors for 4 very important enzymes. The first one is going to be known as the pyruvate dehydrogenase. The second one is the alpha-ketoglutarate dehydrogenase. The third one is the branched-chain keto acid dehydrogenase. These 3 enzymes are the 3 enzymes which are what is known as tending, loving, care for Nancy enzymes, which we'll discuss later, are extremely important in our body. And the 4th enzyme is the transketolase. Now, the pyruvate dehydrogenase is an enzyme which is within glycolysis. The alpha-ketoglutarate dehydrogenase is an enzyme found in the Krebs cycle. The branched-chain keto acid dehydrogenase is an enzyme that is responsible in the amino acid metabolism of the branched-chain amino acids leucine, isoleucine, and valine. And the transketolase is going to be in the hexamonophosphate shunt. Okay? Now, regarding deficiencies of vitamin B1, you should know this, by the way, for all deficiencies, most vitamin deficiencies are going to be some type of malnutrition problem. Whether, they're too poor to afford food, or let's say, they're forcing themselves not to eat like anorexic people, or they have some type of, GI problem where they're unable to absorb the food. In any of those situations, we could get all these deficiencies from some type of malnutrition. Now, in addition, vitamin B1 could also come from, and a lot of times very commonly, from chronic alcoholism. Okay, chronic alcoholism, what happens is basically it binds to thiamine. It doesn't allow thiamine to get into the system. So chronic alcoholisms a lot of times can develop a vitamin B1 deficiency. Now, when vitamin B1 is deficient, what happens is because glycolysis is not working properly, we're unable to make energy. Now, although we have many ways to make energy in a cell, the cells which really rely on glycolysis, because remember, for example, like red blood cells, they rely on glycolysis. Why? Because they don't have mitochondria, and the only way they're making the ATP is from substrate level phosphorylation. So, when we don't have glycolysis, they cannot make ATP, so they cannot support the sodium potassium ATPases. Therefore, what's going to happen is patients could develop hemolytic anemia. Okay. Regarding deficiencies in the alpha-ketoglutarate dehydrogenase, it doesn't function properly. What happens is we can have decreased energy in the cell. The branched-chain keto acid also decreased energy in the cell, and the hexamonophosphate shunt. What happens is when this enzyme is deficient, then we're unable to make the NADPH. And NADPH, of course, what we're going to see later, is extremely, extremely important in oxidizing methemoglobin back to normal and red blood cell healthiness. So if this is going to be deficient, we're going to have low levels of NADPH building up, and therefore we could also progress this hemolytic anemia. Now, regarding B1 deficiencies, it's extremely important that there is a syndrome associated anytime B1 is deficient, and that is known as beriberi disease, or beriberi syndrome. Now, technically, there are 2 types of beriberis. You have what is known as dry beriberi, and you have what is known as wet beriberi. In dry beriberi, what happens is when we have a thiamine deficiency that's causing a dry beriberi, that means that the thiamine deficiency is leading to neurological deficits. Okay, the most common neurological deficit seen in beriberi is going to be some type of progressive neuropathy. Okay. In addition, most patients also appear actually in an emergency setting. They come to you usually some type of altered mental status. So usually, if it's confused, disoriented, a lot of times this could even be coma, and even severe death. A lot of times can happen from these situations. Also, in dry beriberi, another neurological problem syndrome comes up, and it's known as Wernicke-Korsakoff syndrome. And Wernicke-Korsakoff syndrome is characterized by 3 things. Number 1, you have oculomotor problems. Number 2, you have some type of ataxia. And number 3, you have some form of dementia. Okay, that is a Wernicke-Korsakoff syndrome. And of course, this is all result of the thiamine being deficient, the energy not being enough in these certain parts of the brain, which is leading to degeneration and damage to these parts of the nervous system. Now, regarding the treatment for these patients with vitamin B1 deficiency that has a dry beriberi, first of all, you have to understand that these patients a lot of times can present to you in an emergency setting. So, first thing, number 1, of course, is to make sure they're stable. Okay. Number 2, once they're stable, what you want to do is you want to replace the vitamins B1. Obviously, that's obviously with every single deficiency. Replace the B1 levels, and but again, I'm pointing this out over here because usually these people are usually chronic alcoholisms, and because they're chronic alcoholics, B1 has a very hard time being absorbed in the system. So you really have to increase the levels of B1 in these patients in order for them these problems to start regressing. Now, regarding wet beriberi is when we're having a thiamine deficiency that is leading to some type of cardiovascular problem. Okay, usually for some reason, we don't know why this happens, but they have extensive vasodilation. Of course, this leads to increased blood pressure, which eventually will lead to increased very high levels of the renal aldosterone system, which will go back and lead to the absorption of sodium, water, and it leads to a lot of volume overload within our body. And eventually, this increased body volume overload, when it's in the left ventricle, eventually it's going to lead to a pressure overload phenomenon, and that can lead to a dilated cardiomyopathy. And this is why this is extremely dangerous in these patients. Okay. Now remember, dilated cardiomyopathy, like we spoke in cardiology, once you develop a dilated heart, it's dilated forever. So it's extremely important in both these situations to manage and find the problem out right away and treat it early, because this could lead to problems. Okay. Now the next is vitamin B2. Vitamin B2 is also known as riboflavin. Now riboflavin is actually FAD. And now FAD is obviously used to make FADH2. So any enzyme which requires FAD should obviously need riboflavin. Now, what are the enzymes named riboflavin? There are three. The first one is known as the succinate dehydrogenase enzyme. The second is going to be the fatty acyl-CoA dehydrogenase. And the third enzyme is going to be the glycerol 3-phosphate dehydrogenase enzyme. The succinate dehydrogenase enzyme is an enzyme in the Krebs cycle. The fatty acyl-CoA dehydrogenase enzyme is an enzyme within beta oxidation. And the glycerol 3-phosphate dehydrogenase is an enzyme within the glycerol 3 shuttle, or the glycerol shuttle. Okay, now, vitamin B2 deficiencies, again, if there's a deficiency, it's usually going to be from some type of malabsorption problem, but usually you don't have an isolated vitamin B2 deficiency, because we usually have normal amounts of B2, and unless the patient's really going to have severe malnutrition, which is usually going to present with other vitamin deficiencies, so vitamin B2 usually is not going to present to you on its own. Now, of course, because it presents with a lot of different vitamin deficiencies, the patient can have many different symptoms all over the place, but what vitamin B2 specifically likes to cause, they like to cause because for some reason the energy levels for some reason really get messed up in the mouth. So these patients are going to develop problems with their mouth. They could develop stomitis, they could get glossitis, inflammation of the tongue, they could get chapped lips, and problems really with their mouth. They get gingivitis, problems really with the mouth over here. And of course, obviously just fix the deficiencies, and the patient should get better. The third vitamin is going to be vitamin B3. Now vitamin B3, also known as niacin. Now, niacin is extremely, probably one of the most important enzymes. Niacin actually is NAD. Niacin is NAD, and of course, you have to make, in order to make NADH, you gotta have NAD. So all enzymes which use NADH, which is really all dehydrogenases, are going to require niacin to work. So you can imagine if, God forbid, a vitamin B3 deficiency is here, what's going to happen to the person. And what happens to a person is a syndrome, what is known as pellagra. Okay, pellagra is actually a disease which comes from a niacin deficiency, and it's characterized by 3 Ds. The first D is a very severe diarrhea. Patients get major GI inflammation, which lead to a crazy amount of fluid loss, dehydration, hypotension, which can be life-threatening on its own. The second thing is they get very severe dermatitis. Okay, after diarrhea, they usually get dermatitis followed by some type of dementia. Okay, and of course, if this is not healed and this is not fixed properly, eventually the fourth thing is going to happen, and that is going to be these patients are going to die. They're going to get into coma. They're going to die. Now, understand why it's attacking these 3 systems. No one knows why, but technically, it's able to affect any system because remember, any dehydrogenase is in every single cell, so it could technically affect the heart, it could affect the kidney, affect the liver. So it's really unspecific, but usually this is how it presents. Okay, the next vitamin is vitamin B5. Now, vitamin B5 is known as pantothenic acid. Now, pantothenic acid provides a CoA for all enzymes that use CoA. So there are 3 enzymes that use CoA. The first one is going to be the pyruvate dehydrogenase enzyme. The second enzyme is, again, also alpha-ketoglutarate dehydrogenase enzyme. And the third enzyme is going to be the fatty acyl-CoA dehydrogenase, synthase enzyme. Okay, the pyruvate dehydrogenase enzyme is the enzyme, again, in glycolysis. The alpha-ketoglutarate dehydrogenase enzyme is the enzyme, remember, in the Krebs cycle, again. And the fatty acyl-CoA dehydrogenase is an enzyme within the beta oxidation. Now, just to tell you quickly, the pyruvate dehydrogenase takes pyruvate and turns to acetyl-CoA. The alpha-ketoglutarate dehydrogenase is responsible for taking alpha-ketoglutarate and turning to succinyl-CoA, and the fatty acyl-CoA dehydrogenase is responsible for taking fatty acid and turning to fatty acyl-CoA. Okay, very important. Now, when vitamin B5 is deficient, again, vitamin B5 deficiencies usually don't happen. because it's really very high levels in our body. But if it does happen, patients can develop very, very severe neurological problems. We usually don't see it, so it's not something I doubt will be on the board exam. Vitamin B6 is referred to as pyridoxal phosphate. Now, pyridoxal phosphate is a cofactor, which is important for two very, very important enzymes. The first one is going to be called the aminolenic acid synthase enzyme, and the second one is going to be called the aminotransaminases enzymes. The alpha aminolenic acid enzyme, synthase, is an enzyme which is required in the heme synthesis. And the aminolenic acid enzyme is going to be in all ammonia detoxification. Now, vitamin B6 is an extremely important enzyme. Again, it's most commonly caused by some type of malnutrition. That's why it's deficient. But technically, B6, remember, because the aminotransaminases are so much abundant in the liver, and because they're always active. So if we're going to have a liver which is chronically working very hard, and it's really working overtime, what's going to happen is that this can actually deplete all the vitamin B6 storages. And therefore, when of course this is depleted, number one, what's going to happen is when the alpha aminolenic acid synthase doesn't work properly, what's going to happen is you're going to have low levels of heme, which obviously leads to low levels of hemoglobin, which is going to lead to a microcytic anemia. And when ammonia obviously cannot be broken down, what's going to happen there is we're going to have hyperammonemia, whatever you want to call it. And of course, we'll discuss what are the symptoms and everything over there. Okay. Next is vitamin B7. Now, vitamin B7 is called biotin. Now, biotin, again, it's most commonly from malnutrition, but again, we usually have enough biotin in our system where malnutrition usually doesn't cause a vitamin B7 deficiency. However, there is one way to get a vitamin B7 deficiency, and that is people who chronically, on an everyday really basis, eat raw eggs. See, in the white of the eggs, there's a protein known as avidin. Avidin, when it gets into your GI system, it doesn't allow biotin to be absorbed. So if you chronically eat raw eggs every day, you could develop a biotin deficiency. Again, but it's not really common here. I doubt you'll ever see it. But again, technically, people who do eat raw eggs can get biotin deficiencies. Now, first of all, biotin provides an extremely important enzyme, cofactor for all carboxylases. Okay, so any enzyme which is a carboxylase is going to require biotin, and there are three very important ones. You have the pyruvate carboxylase, you have the acetyl-CoA carboxylase, and you have the propionyl-CoA carboxylase. The pyruvate carboxylase is an enzyme within gluconeogenesis. The acetyl-CoA carboxylase is an enzyme within the fatty acid synthesis, and the propionyl-CoA carboxylase is an enzyme that is very important in the vomit pathway, which we'll discuss later. Now, deficiencies in biotin. What happens is when biotin is deficient, for some reason, dermatitis likes to happen, and very bad skin problems. In addition, also patients like to get alopecia. Again, we don't know why this happens, but those are the two most common presentations. Also, understand, because, very, very important, we don't have gluconeogenesis here, so patients will develop fasting hypoglycemia. And that's really what kills these patients, unfortunately, when they have a biotin deficiency, is they don't know they're biotin deficient and they get very severe fasting hypoglycemia. Okay? Next is vitamin B9. Now, vitamin B9 is folic acid. Folic acid, again, we're not going to discuss now. We're going to leave this till later on in the lecture. But B12, okay, B12, also known as cyanoalbumine, so vitamin B12, also known as cyanocarbamylase, is an enzyme which is extremely important in two very, very important enzymes. The first one is going to be the homocysteine methyltransferase enzyme, and the second one is going to be the methylmalonyl-CoA synthase enzyme. Okay, the homocysteine methyltransferase enzyme is extremely important in regarding with folate synthesis, and the methylmalonyl-CoA synthase enzyme is an enzyme that is in the vomit pathway. Okay. Now, vitamin B12, again, of course, you get it from some type of malnutrition, but vitamin B12 deficiency, very specifically, and this is unique, the most common cause of vitamin B12 deficiency is what is known as pernicious anemia. Pernicious anemia, what happens is basically, is you have antibodies binding to parietal cells. And when parietal cells get bounded to, they're unable to release intrinsic factor. Now, because intrinsic factor cannot go, well, normally what does intrinsic factor do? Intrinsic factor basically goes to the GI system and allows B12 to be absorbed. Now, because we're having antibodies binding to parietal cells and not able to release intrinsic factor, so B12 cannot be absorbed, therefore we get B12 deficiencies, okay? In addition, B12 deficiencies can also come from certain parasites. Certain parasites in the person's intestines can absorb all the B12. In addition, normally when you take B12, it has a certain protein guarding it, known as called an R binder. And normally R binders, in order for B12 to get absorbed, R binders have to be broken down off the B12. Now, if a person has, let's say, some type of pancreatic insufficiency, where they're not making the pancreatic proteases to break down the R binders, then B12 cannot be absorbed, and we could develop a B12 deficiency as well there. Now, regardless of how we're getting a B12 deficiency, what is going to be the symptoms of B12 deficiency? Well, the first thing, again, if we're unable to make folate, what's going to happen is that people could develop a megaloblastic anemia. Why? Because normally, well, first of all, folate is obviously required for cells to multiply. It's required for cells to mature. Now, normally red blood cells start off very big, and normally when they mature, they get smaller and smaller and smaller. Now, if we don't have folate, cells aren't able to mature, which means red blood cells aren't able to mature, which means they get dumped into the blood when they're very, very fat and big. And then, of course, that's linked to megaloblastic anemia. Now, the second thing is with vitamin B12 deficiency is it likes to cause neurological problems. It's called subacute combined degeneration of the spinal cord. It's a weird disease. It basically likes to attack the lateral horn in the spinal cord. Again, it can honestly cause any disease, any neurological deficits, but it most commonly likes to cause progressive peripheral neuropathies. Also, very important, syphilis can also cause subacute combined degeneration of the spinal cord. So keep that in mind as well. Okay, and of course, with all these deficiencies, what you would want to do is you want to just replace the levels, and it should go back to normal. Okay. Now, regarding the lipid-soluble vitamins, for vitamin A can be stored in the liver cilia cells. Now, depending on what group vitamin A is attached to, it can actually have three groups it could be in. The first one is going to be, if it's attached to a carboxyl group, it's going to be a retinol. If it's attached to a hydroxyl group, it's going to be retinoic acid. And if it's attached to an aldehyde group, that's going to be retinal. Okay? Now, technically, retinol and retinoic acid are very important because they provide healthy function of our normal epithelium cells. Okay? While retinal actually functions in the rod cells within the rhodopsin complex. The rhodopsin complex basically is a photon receptor which normally during the day is not activated. Why? Because there are too many photons basically, that desensitizes this complex. Now, when this complex is really active is during the nighttime, where there's very little photons flying around. Therefore, this is really our night vision. And what happens is that retinol over here is basically at the tail of this rhodopsin complex. Now, normally it's in what is known as transformation. And when a photon will stimulate the rhodopsin complex, it will go from trans to cis formation. And when its cis formation retinol is activated, this is going to activate a G protein, which in turn is going to activate the cyclic GMP phosphodiesterase, which is going to take cyclic GMP and convert it into 5-GMP. Now, why is this important? Because normally cyclic GMP, its function is to go and actually open up sodium channels, which will lead to a sodium influx into the cell. And when sodium gets high in levels in the cell, we're going to have obviously a depolarization. Okay? And when the cell gets depolarized, what happens is, specifically when this rod cell gets depolarized, it's going to release glutamate. Glutamate is going to stimulate a bipolar cell. Bipolar cells, as you know, obviously release GABA. And it's going to release GABA on the optic nerve. So, the purpose of this is, when a photon will stimulate the rhodopsin complex, this will lead to the G protein stimulation, which will lead to the activation of the cyclic GMP phosphodiesterase enzyme, which will go and convert cyclic GMP to 5-GMP. The purpose of that is because we don't want to release glutamate to stimulate the bipolar cell to inhibit the optic nerve. So, if we make 5-GMP, we're not going to inhibit the optic nerve. And that is why the rhodopsin complex is important during night vision. So, If a patient, God forbid, let's say he has a vitamin A deficiency. So what's going to happen here is, number one, you're not going to have night vision, okay? But more importantly, if the epithelium, we're not going to have the epithelium, our lungs, specifically, this likes to affect the lungs. Our lungs are going to go into metaplasia, and they're going to develop squamous cell metaplasia. And of course, squamous cell metaplasia in the lungs isn't good. That's going to increase respiratory infections. So that's the first thing with these patients. Number two, it likes to affect the hair. It likes to cause what is known as a follicular hypertrichosis, which eventually can lead to alopecia and hair loss. And the third thing what it likes to go and affect is the eyes. The eyes are very, very sensitive. What happens is, if we have metaplasia in the eyes become very dry. When they become dry, when we blink, we're going to keep on scratching the cornea. And eventually, after a while, what happens is the cornea can develop very, very severe ulcers, which is known as Bitot spots. And if you let Bitot spots progress, that can lead to what is known as correctomalacia, which is extremely, extremely dangerous, and that can lead to blindness in these patients. So vitamin A is definitely something that should not be underestimated. Now we're going to vitamin D. Vitamin D, again, we can get vitamin D either from our diet, and we can actually even make vitamin D. How do we make it? So when the UV rays go and actually activate on our skin cells, it will convert a product which is known as dihydrocholesterol to cholecalciferol. That's step number one. Once cholecalciferol is produced, it will go to the liver, where the liver's 25-hydroxylase enzyme is going to convert cholecalciferol to 25-cholecalciferol. Okay? That's the second step. The third step is the 25-dihydroxycholecalciferol will go into the kidney, specifically the proximal convoluted tubule in the kidney, and over there, the 1-alpha hydroxylase is going to go and convert 25-dihydroxycholecalciferol to 1,25-cholecalciferol. And this 1,25-cholecalciferol is the active vitamin D. And the active vitamin D does really three things. The first thing, it will go to the GI system and lead to the reabsorption and the absorption of calcium, thus increasing calcium in our body. Number two, it's going to go to the kidney, and it's going to activate the reabsorption transporters to absorb, number one, calcium, and number two, it's going to increase phosphate levels. Now this is actually the difference in the PTH. PTH only gets calcium, vitamin D gets calcium and phosphate. And the third thing that it's going to do is, actually, this is only when it's high levels. At high levels, vitamin D can actually go and stimulate osteoclast. And of course, osteoclast can go break down bone, leading to increased levels of calcium as well. Vitamin D deficiencies, again, of course, you're going to have hypocalcemia. You could have also hyperphosphate in the system. Again, we'll discuss this when we deal with in endocrinology, specifically what happens with vitamin deficiencies. Now, regarding vitamin E, is extremely, extremely important antioxidant. Okay, extremely, extremely important antioxidant. And of course, many diseases and many problems develop when we don't have this antioxidant problems. We could develop hemolytic anemias, we could develop atherosclerosis, and a lot of times what happens if vitamin E is deficient, we could develop brain problems and CNS problems. So it's very important to give vitamin E. Now, vice versa, if you give too much vitamin E, what happens is it really antioxidants so much that vitamin K's function becomes altered. Why? Because vitamin K is responsible for gamma carboxylation of coagulation factors 2, 7, 9, 10, protein C, and protein S. And this is extremely, extremely important because these proteins, if you know a little about coagulation factors, obviously we'll discuss this a lot more in hematology, but coagulation factors have the tendency to sleep. And unless they're waking up, they're not going to do anything. And even once they're woken up, they still have the tendency to run away and go back to sleep. Now, during, let's say, a bleeding process where coagulation factors are actually activated, to prevent them from running away, what happens is we actually have to handcuff them. So what the gamma carboxylation basically is basically a negative charge on these molecules, which will go, and when it passes an injured tissue, calcium, of course, is all over the site, and calcium is going to go and it's going to bind to this negative group. And of course, that is going to go, and that's going to lead, obviously, to the trapping of these molecules. Okay, so that is basically the vitamins you need to know for now. I highly suggest again that after we finish the biochemistry, you'll go through this chart, you go back to this section, and you will understand this, and you will really appreciate the different cofactors and the different enzymes of how they're functioning and how they're really working in our system. That's done.